You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about low gradient, bicuspid, unicuspid, subvalvular, and supravalvular aortic disease. Let's start with low gradient aortic stenosis. Many patients with aortic stenosis can be easily classified into moderate aortic stenosis or severe high gradient aortic stenosis based on whether the aortic valve area is above or below 1.0 centimeters square, whether the aortic valve area index is above or below 0.6 centimeters square per meter square, and whether the mean gradient is above or below 40 millimeters of mercury. However, 40% of patients with aortic stenosis have discordant Doppler findings on echo, the most common of which is small aortic valve area, less than 1 centimeter square, suggesting severe AS, but low gradient, less than 40 millimeters of mercury, suggesting non-severe AS. These low gradient aortic stenosis patients can be classified into three types based on their LV ejection fraction and flow status. If LV ejection fraction is less than 50%, then this is classical low flow, low gradient aortic stenosis, LFLG aortic stenosis. It's actually the least common low gradient aortic stenosis. If LVEF is preserved at 50% or higher, then you look at the flow status as measured by the stroke volume index or SVI. If the stroke volume index is less than 35 millimeters per meter square, it is paradoxical low flow, low gradient aortic stenosis. If the stroke volume index is more than 35 milliliters per meter square, then it is normal flow, low gradient aortic stenosis, which is the most common low gradient aortic stenosis. Let's start with classical low flow, low gradient aortic stenosis. This is aortic stenosis that has aortic valve area of less than 1.0 centimeters, mean pressure gradient less than 40 millimeters of mercury, and LVEF of less than 50%. It comprises 5 to 10% of the aortic stenosis population. Almost all of these patients have coronary artery disease and reduced ejection fraction from ischemic cardiomyopathy with an enlarged LV cavity and sometimes resulting functional mitral regurgitation. The reduced ejection fraction can either be due to the ischemic cardiomyopathy or it could be due to afterload mismatch from severe aortic stenosis or both. Classical low flow, low gradient aortic stenosis is labeled as stage D2. The 2020 valve guidelines upgraded it from a Class A to a Class 1 recommendation for aortic valve repair. This, again, is classic low flow, low gradient aortic stenosis. Meanwhile, paradoxical low flow, low gradient aortic stenosis is aortic stenosis that has aortic valve area less than 1.0 centimeters square, mean pressure gradient of less than 40 millimeters of mercury, but preserved LV ejection fraction of more than 50% and stroke volume index of less than 35 milliliters per meter square. Paradoxical describes the unexpectedly low stroke volume despite the preserved ejection fraction. It comprises 5 to 15% of the AS population. While classical low flow, low gradient aortic stenosis usually occurs in men, paradoxical low flow, low gradient aortic stenosis usually occurs in women and the elderly. Paradoxical low flow, low gradient aortic stenosis patients tend to have small LV cavity with LV concentric remodeling and restrictive physiology, leading to reduced SV stroke volume despite having a preserved LV ejection fraction. Other ways that they may end up with low stroke volume index are having significant mitral regurgitation, mitral stenosis, tricuspid regurgitation, or AFib. Paradoxical low flow, low gradient aortic stenosis is labeled at stage D3. The 2020 valve guidelines upgraded it from a Class 2A recommendation to a Class 1 recommendation for aortic valve replacement. Again, this is paradoxical low flow, low gradient aortic stenosis. Now, how about normal flow, low gradient aortic stenosis? That is aortic stenosis that has an aortic valve area of less than 1.0 centimeters square, mean pressure gradient of less than 40 millimeters of mercury, preserved LVEF of more than 50%, and stroke volume index of 35 milliliters per meter square. It comprises 25% of the AS population and is the most common type of low gradient aortic stenosis. It is unnecessary to pursue dobutamine stress testing in normal flow low gradient aortic stenosis because the flow does not need to be augmented. If the situation is classical low flow, low gradient aortic stenosis, which by definition has reduced EF, then your job is to distinguish between true classical low flow, low gradient aortic stenosis from pseudo-severe aortic stenosis, which is incomplete opening of a moderately stenotic aortic valve in the setting of a low flow state, and which improves, i.e., increased leaflet opening, when exercised. It is important to distinguish between this true severe aortic stenosis, true classical low flow, low gradient AS, from pseudo severe AS, which is the classical low flow, low gradient AS that has increased tri-leaflet opening on exercise, because true severe AS benefits from AV replacements, whereas pseudo severe AS does not benefit from aortic valve replacement. How can you make this distinction? By performing dobutamine stress echocardiography. Now, when you do dobutamine stress echocardiography, you need to know when to terminate if it is being done for low flow low gradient aortic stenosis. You keep going until the maximal dosage is reached, which is 20 milligrams per kilogram per minute. Yet, if it's non-diagnostic, no contractile reserve, which is failure to increase the stroke volume by 20%, that is time to stop. Another reason is if you have a positive result obtained. So, a positive result on a dobutamine stress echo that's being done specifically for low flow, low gradient aortic stenosis is either an increase in the effective aortic valve area to a final area more than 1 centimeter square, suggesting that the AS is not actually severe, or severe aortic stenosis is confirmed as suggested by the AS jet velocity exceeding 4 meters per second or mean gradient more than 30 to 40 millimeters of mercury, provided that the aortic valve area does not exceed 1 centimeter square at any flow rate. Also, if the heart rate rises 10 to 20 above baseline heart rate or exceeds 100, that's another reason you can terminate the dobutamine stress echo, or if the patient develops symptoms, blood pressure falls, or if there's significant arrhythmia, also another reason to stop the dobutamine stress echo. If the dobutamine stress echo is unable to induce a sufficiently high increase in a flow rate, you'll need at least a 15% increase in stroke volume to be sufficient. Then dobutamine stress echo would be considered non-diagnostic. When DSC is non-diagnostic, or in cases where the patient has other contraindications preventing them from doing stress echo, you can do AV calcium scoring, aortic valve calcium scoring, by multi-detector computed tomography, or MDCT. MDCT has high accuracy and is independent of flow and spares the patient from needing to be stressed, and also does not require contrast. It reflects anatomic severity rather than hemodynamic severity. If the aortic valve calcium score exceeds 2,000 AUs in men or 1,200 AUs in women, or if the aortic valve calcium density is more than 500 AUs per centimeter square in men or more than 300 AUs per centimeter square in women, that suggests true severe aortic stenosis instead of pseudo-severe AS. Now, we'll move on from low gradient aortic stenosis to bicuspid aortic valve. Bicuspid aortic valve affects 1% of individuals and is autosomal dominant, so all first degree relatives should be screened with echo. In patients with bicuspid valve, approximately 10% of first degree family members screened also have bicuspid valves. The male to female ratio is 3:1 for bicuspid aortic valve. Bicuspid aortic valve can also have significant aortic valve regurgitation, which can result in enlarged and laterally displaced apical pulse, decrescendo diastolic murmur, wide aortic pulse pressure, and an S3, in addition to the usual aortic stenosis finding of systolic ejection click with crescendo decrescendo systolic murmur. 20 to 30 patients 20 to 30% of patients with bicuspid aortic valve also have family members with bicuspid aortic valve or aortopathy. So, all first degree relatives of a patient diagnosed with BAV should be given a screening echocardiogram. If you have a bicuspid aortic valve patient who is refractory to 3 to 4 antihypertensive agents, you must look for aortic coarctation, which is most commonly a discrete narrowing of the descending aorta at the insertion of the ductus arteriosus. Other findings on physical exam of coarctation of the aorta are systolic hypertension in the upper extremities with low or unobtainable arterial blood pressure in the lower extremities, diminished or delayed pulses femorally, that's the brachial femoral delay, or systolic murmur extending beyond the second heart sound at the left paravertebral interscapular area due to flow across the narrow coarctation area. If you diagnose somebody with bicuspid aortic valve, check whether they also have ascending aortic aneurysm, aortic coarctation, supravalvular or subvalvular aortic stenosis, ventricular septal defect, or PDA. The most common one is ascending aorta dilation, which occurs due to cystic medial degeneration and hemodynamic consequences of the eccentric aortic outflow jet. 60 to 80% of patients with coarctation of the aorta also have bicuspid aortic valve, but only 6% of bicuspid aortic valve patients also have coarctation of the aorta. ASDs and VSDs are common findings in coarctation of the aorta, but not as common as bicuspid aortic valve is found in coarctation of the aorta. Again, 60 to 80% of patients with coarctation of the aorta has bicuspid aortic valve, so it's a much more common finding than ASDs and VSDs in bicuspid in coarctation of the aorta. Among Turner syndrome patients, 15 to 30% have bicuspid aortic valve, and 7 to 18% have coarctation of the aorta. Aortic MR angiography or CT angiography is indicated in patients with a bicuspid aortic valve when the ascending aorta cannot be fully assessed and or if the echo cannot exclude aortic coarctation. 50% of bicuspid aortic valve has ascending aorta dilation. Bicuspid aortic valve can have short left main coronary arteries or separate ostia of the left coronary arteries. The most common, 70 to 85% combination of cusp fusion in bicuspid aortic valve is left and right coronary cusp fused, and the non-coronary cusp is by itself. This is called RL pattern. The second most common, which is 15 to 25% pattern, is RN fused pattern, and L is by itself, which means the right coronary cusp and the non-coronary cusp are fused, and the left is alone. Less than 5% of cases has LN fused R alone. That means it's rare to have the left and non-coronary cusp fused and the right coronary cusp by its alone. Pure BAV, which is symmetric and having no raphe, is rare. It's usually a 2/3 and 1/3 kind of thing rather than a half and half kind of thing. Now we'll move on from bicuspid aortic valve to unicuspid aortic valve. A unicommissural unicuspid aortic valve, UAV, has a single commissure attached to the aortic root. The usual clinical presentation is in the 3rd to 5th decades of life. The most common presentation is mixed aortic stenosis and regurgitation. UAV can be easily confused by bicuspid aortic valve, BAV, with which it shares common features such as thoracic aortopathy. But overall, unicuspid is very rare, so that's all I will say about it. Now let's move on to subvalvular aortic stenosis. Subvalvular aortic stenosis may occur as a discrete membrane below the aortic valve in the LV outflow tract, as a longer tunnel-like obstruction, as a consequence of chordal attachments in patients with abnormalities such as AVSD, or because of surgical repairs involving the BSD baffled to a transposed aorta, such as seen in the Rastelli operation. Subvalvular AS may be found in isolation or as part of a suite of abnormalities such as Shone complex, which is a complex of 4 obstructive lesions in a left heart, supravalvular mitral membrane, in addition to the parachute mitral valve, subvalvular mitral membrane, subaortic membrane, and aortic coarctation. Anytime you hear a patient with multiple left heart obstructions, check if it fits the 4 criteria of Shone complex. If you diagnose subvalvular aortic stenosis from a subaortic membrane, you need to also evaluate for coarctation of the aorta, PDA, pulmonary valve stenosis, and VSD. On physical exam, the murmur for subaortic stenosis is an ejection murmur heard at a midsternal border without an associated valvular click. In terms of imaging findings, if you see elevated transaortic valvular gradients but normal appearing aortic valves in a young person, suspect subvalvular obstruction, which can occur from a subaortic membrane. To figure out if AS is subvalvular, apply color Doppler and see if aliasing of the velocity occurs below the aortic valve, suggesting that flow acceleration is occurring at the subvalvular level. You can also do PW Doppler to figure this out. Echo features of subaortic membrane you can see on 2D echo are thin linear membrane beneath the aortic valve in the LV outflow tract, tenting at the base of the anterior mitral leaflet where the circumferential extent of the membrane attaches to the mitral valve. The most common type of subaortic stenosis is a discrete subaortic membrane proximal to the aortic valve within the LVOT. The membrane is most often circumferential and can be adherent to both the aortic valve as well as the anterior leaflet of the mitral valve. In terms of intervention, subvalvular AS does not respond to balloon dilatation. You need to surgically resect. The 2018 Congenital Heart Guidelines say surgical intervention is recommended for adults with subvalvular AS, a maximum gradient of 50 millimeters of mercury or more, and symptoms attributable to the subvalvular AS. That's a class 1 recommendation for surgical resection. Surgical intervention is recommended for adults with subvalvular AS and less than 50 millimeters mercury maximum gradient and heart failure or ischemic symptoms and or LV systolic dysfunction attributable to subvalvular AS, class 1. In other words, they recommend surgical resection. Both are class 1 if the gradient, the max gradient is more than 50 millimeters of mercury and symptomatic, then you can go with that. If it's less than 50 millimeters mercury, then you want to see if there's any heart failure, signs of LV systolic dysfunction, or ischemic symptoms, and then you can go ahead with the surgical resection. Interestingly, they also allow for surgery if there is asymptomatic subvalvular adults as long as the gradient is over 50 millimeters of mercury. So they say to prevent the progression of aortic regurgitation, surgical intervention may be considered for asymptomatic adults with subvalvular AS and at least mild AR and a maximum gradient of 50 millimeters of mercury or more. That's a class 2B recommendation. This is because discrete subvalvular AS tends to be progressive with age, and patients with a resting maximum gradient of more than 50 millimeters of mercury are more likely to have progressive subvalvular AS and concomitant moderate or severe aortic valve regurgitation. Surgical repair for subvalvular AS carries a 15% risk of complete heart block. Now, we'll touch upon our last topic of this episode, which is supravalvular aortic stenosis. Supravalvular aortic stenosis is much rarer compared to subvalvular and valvular aortic stenosis. When it occurs, supravalvular AS usually is in the setting of Williams syndrome or homozygous familial hypercholesterolemia, which, as you know, is much rarer than heterozygous familial hypercholesterolemia. Unlike subvalvular or valvular AS, in supravalvular AS, the coronary arteries are exposed to the higher pressure generated by the supravalvular obstruction. Supravalvular aortic stenosis usually has a calcified ascending aorta. The poststenotic jet is a high velocity jet that propagates further than the jet would occurred if it was aortic valvular stenosis. And due to the Coanda effect, preferentially trains along the aortic wall, thereby transferring its kinetic energy predominantly into the right innominate artery. That's why patients with supravalvular aortic stenosis have higher right arm blood pressure than left arm blood pressure. In terms of intervention, according to the 2018 Congenital Heart Disease Guidelines, surgical repair is recommended for adults with supravalvular aortic stenosis, discrete or diffuse, and symptoms or decreased LV systolic function deemed secondary to aortic obstruction. That's a class 1 recommendation. Coronary artery vascularization is recommended in symptomatic adults with supravalvular aortic stenosis and coronary osteostenosis, class 1. That's all for low gradient aortic stenosis, bicuspid AS, unicuspid AS, subvalvular AS, and supravalvular AS. In the next episode, we'll talk about aortic valve replacements.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.